Okay, why don't we get going? I think more are joining, but I think given we don't have a long session, so um, it'd be good to get started to give our speakers adequate time. Welcome to our Vaccine Confidence webinar series. I'm Heidi Larson, the director of the Vaccine Confidence Project, and really thrilled to invite a great panel today. This is a slightly different angle of topic in our series, and we're really going to be looking at the what we're framing as the emotional determinants of health. We've taken this title from a new Lancet commission that we announced in the Lancet in March, which will be looking at well beyond vaccines, but how emotional and psychological issues can affect people's choices in terms of their treatments, in terms of their prevention methods, and just and determine their health in general. So in this exchange today, in the context of COVID, which is rife with a lot of emotions, hopes as well as fears, we are bringing together a great panel, which I'm, as I mentioned, thrilled to have. And we're going to start in the first panel with a perspective from Joanne Liu, who is well known in her being the former president of MSF, Médecins Sans Frontières, and is currently at McGill University and works and is an expert in emergency medicine, pediatrics in particular. And so she'll kick off and tell us, share some thoughts in terms of the healthcare professional perspective. And then we'll shift to Professor Kiermaier, also from McGill, who is in the social and transcultural psychiatry department, but we'll be looking at some of the issue of situated emotions, how emotions are determined by your different situations. And certainly the current context and situation that we're all in around the world has been one that has certainly been a strong lever of our emotions. So without further ado, as they say, I'm happy to introduce Dr. Joanne Liu. Thank you.
Thank you very much, Heidi, and good morning, good afternoon, and good evening to all. It's my distinguished pleasure to be here, and then that topic is a topic that I have a certain passion for, and I'll tell you my reason why I have a passion for. But I just want to disclose first of all that I'm going to put an emphasis on professional, medical professional, but I am not, I would say. I just want to make sure that people know that I understand that there is like the same sort of difficult emotion through all frontline worker as well as general population or affected people by the disease. So what I'm going to talk about is no, it doesn't come from any studies, but it's basically what I have observed in tackling different epidemic and pandemic across the world over the last few decades. And so what I've noticed is the fact that we have what I call patterns. There are patterns in epidemics, patterns about how a healthcare worker go through it, and or sometimes I call it behavior of epidemics. But basically, initially, and it's always the same thing. Is people, healthcare worker, we and I've been in the spot of being a frontline worker as well as being someone who are managing at the macro level epidemic. But there's three pillars that sort of I would say shape the emotion of a healthcare worker. For what I observe it's we are torn between our duty to care, we between as well. Making ourselves safe, so our biosafety, and then keeping our mental sanity in the chaos of tackling a deadly disease. A lot of what I've said is it's true epidemics like Ebola, because I think Ebola was a good example. And how does it translate today in COVID-19? But one of the things is initially it's the way it works is what do we find generally is every single healthcare worker is tremendously committed and wants to do everything, and initially is everybody's running on adrenaline. And then what happened after a while, when we're putting things in place, is all sort of things happen in the fact that people are getting exposed, and then people are realizing that in the society they are treated differently. They are treated differently because of their exposure, and so it affects every single aspect of their life, and therefore create all sort of different emotion. And one of the things that we see over and over again is it's the fact that although everybody knows the duty to care for patient, fear is always there, and fear will never go away. I remember when I was working in West Africa, in Ebola, and in DRC, our doctors and nurses told us it's like being at a front line in a war zone and having a gunship firing at us all the time. No downtime, all the time. And even if people are working 24/7, the reality is it never leaves them, because when they are in the hospital, when in the healthcare system attending to patients who are infected, they have to wear their PPE, the personal protective equipment. They have to protect themselves. They have to go through all sort of, I would say, way of working that is different than usually, to make sure that they don't infect themselves and they don't infect others. And then when they go home, then and then they are scared of infecting their loved one, and that will never leave them. This is something that stay with them, and it creates this emotion of, in addition to fear, of guilt, and of, I would say, of yeah, mainly guilt, and deep concern of infecting other people. So this is what people go through, but initially people live with it, because like because it's the beginning of an epidemic, like you've seen in Europe, with COVID-19, and in Canada, is the fact that and across the world, is everybody is paying attention initially. And we all remember when people were clapping their pots or clapping their hands every single evening in Europe, and to just thank the healthcare worker. And it is so important. That is very little, but the transfer of positive emotion on the healthcare worker gave us this extra edge to continue to work. But what happened is, after several months, everybody is wearing out. Everybody's fatigued about it, and then this is what I call the burnout of the system. Everybody going to burnout, or general fatigue. It's the wear and tear of the response, and all of a sudden, all this emotion start to be rechanneled in some sort of anger. And then it's what we saw in Ebola, and we saw as well in the cholera epidemic in Yemen, was the fact that after several months, people wanted to, in addition to be recognized by the community and by the authority, they wanted to be compensated, or they wanted to have tangible compensation. And people went on strike, I remember, in West Africa, because we were promising them to get what we call a risk incentive that never came, or really came very, very late. Here in Canada, it's a different thing, but it's amount about the same thing. Is the fact that the healthcare worker didn't get vacation over the summer, over the month of July and August, which is the usual month that people are taking vacation. So they didn't get that sort of compensation. And in addition to that, what we see in many of our emergency room in Montreal is people, because we're short of staff, nurses especially, have to do compulsory overtime. And so all this wear and tear is something that often is overlooked, and that wear and tear create emotion of anger, emotion of being overwhelmed, and it really jeopardizes the delivery service. And it's a very, very difficult, rough patch to go through. And then and the reality is nothing is over. And so there's always somehow, and then just to finish my intervention on hope, is there's always somehow something that happens at one point, at a breaking time. People start to understand that human beings are not machine, that human beings have emotion, and they may have resentment, and we have to address that. We start to support them. And most of the time the miracle happen, not only from the authorities, but of the fact that collectively community owns the epidemic. And I always say that epidemics start in the community and stop in the community. And what's going to make us, us, the professional worker, to pull through is that as well, collectively, the community is going to continue to back us up. And then we don't want to be applauded every night, and we don't want to be always call you guardian angel, but we need the public support and the community support to get us to pull through. And for us, it means that the behavior of the community is key. The behavior of respecting and being compliant to try to, I would say, tame the epidemic in a number of cases is key. And when we see that, I guess it gave us the energy to keep going. Thank you very much.
Thanks very much, Joanne. That's a really powerful way to start the webinar with the human sentiments that I think at multiple levels, this sense of, as you say, you kind of go from energized with adrenaline to a kind of fatigue to burnout to hoping for hope, and the role of the community and society more broadly. There was a really excellent article in 2009. It was a personal story also from a doctor in the New England Journal that talks about the epidemiology of emotion. Or the emotional epidemiology, and she talked about, and initially the eagerness of some of her patients and the threat of the pandemic, initial threat, but then by the time vaccines and things were there, they had worn out, and then in the meanwhile. But anyway, and on that note, thank you very much. And now we'll turn to Professor Lawrence Kiermaier to give us a different perspective, but I think quite complementary. So I'll turn over to you. Thanks very much.
How do I do that? Am I unmuted? No, I have to come out of this. Hang on.
We hear you now.
You can hear me? Okay, sorry, because what happens here is I cannot see my menus when I go into SlideShare, and I can't even see my cursor, which is particularly exciting. Okay, let me begin again. So I began by saying really that I'm very glad to have this opportunity to join all of you and to begin this conversation about the importance of emotions in understanding the current pandemic and pandemic response and its impacts, and more broadly in global mental health. What I'd like to do in the next 5 to 10 minutes is lay out a bit of a framework for thinking about emotions and global mental health through the vehicle of looking at the current pandemic and the bit of information that we have at the level of mental health. The context that I come from is a program at McGill that's devoted to looking at culture and mental health, and that's what I'm going to emphasize as we go through this. So very briefly, I'll say some words about culture and context in global mental health generally. I'll talk a bit about the varying contexts of COVID around the world and the impacts, the evidence we have for the impacts of COVID-19 and its mitigation efforts on emotional distress. And then I'll focus in on how to think about emotions in cultural context and what an ecosocial approach to culture and emotional distress might look like. I have a bunch of slides which I will skip over and I'll just make available to all of you afterward, because there's sort of just ways to point toward things that I think are important, but that we won't have time to really introduce. Just to say that the current thinking about culture is a kind of many-dimensional social matrix that shapes us across all of development, that mostly is taken for granted, that it forms part of our background knowledge, but that it varies substantially within and across societies. So that's a challenge for us in healthcare in terms of responding to people in ways that fit their own local reality. This is important in the context of global mental health, because the dynamics of global health and global mental health have largely followed the older dynamics of colonialism. That knowledge has been sort of produced in the global north and transmitted or shared with the global south, and we're moving toward a much more dialogical process in which we learn from each other and in which we don't automatically assume that we have all the right answers. We know that there are many stories of failures of well-intended programs because of a lack of attention to context. So we're very much concerned with trying to frame that context. What are the contexts of COVID? They're hugely variable contexts, notwithstanding the fact that the virus has moved around the world, mutated in different places and so on. And there's a temptation always with something like an infectious disease and other biological processes to assume universality. And yet the reality is that individuals, groups, communities are all situated in very different contexts that affect both their vulnerability to infection and the ways that they respond to all the mitigation efforts that are going on. And these are just some of the dimensions that we need to think about and talk about in terms of the kinds of social spaces people are occupying, how they make their livelihood, what kinds of resources they have if they need to be confined, what kinds of dynamics there are between groups. We've seen a rise in many parts of the world, here in Montreal, among other places, of intergroup hostility, of discrimination attached to people who are perceived as Asian because of this association of the virus with its geographic origins. And those become very important causes of problems in their own right, and factors that interact with anything we might want to do to address the problem from a public health point of view. When we're talking about COVID in the present moment and emotions, what looms as large as the virus, or larger in most people's lives, are the public health measures that are being taken to try to slow the spread of the virus and limit its impact. And those have profound effects on every facet of our lives. So this is the sort of changed social context, the changed cultural worlds that we're living in, that we are groping around in trying to gradually make sense of. The fact that humanity's lived through global pandemics in the past gives us some kind of point of comparison, but there's some important differences in the present moment, most notably the high degree of global interconnection, and in particular electronic interconnection. And for those of us living in wealthy countries with big information highways, the fact that we can live a good part of our lives online at the moment. This has really greatly accelerated a process that has been going on in any event. So this is just, I've taken things from the current literature, people's attempts to put these together. Here's a diagram that just reminds us of some of the many impacts on mental health that are associated with the current pandemic. And these include social structural things, different kinds of fears, different kinds of constraints, major losses that people are experiencing in many domains, all of which are powerful elicitors of emotional responses, both acutely and over time, both in terms of repeated events and in terms of the wear and tear of a persistent predicament that people are experiencing. And I'll come back to that. I think the temporality of the current situation is a very important dimension of it. It's one thing to go through a kind of lockdown that you think is very time limited, and it's another thing to get partway through it and be told, as we just were here in Montreal, no, it'll have to be a few more weeks and a few more weeks, and maybe by Christmas and so on. So this kind of shifting sense of what the horizon is of when an event is going to have some end is a major part of the uncertainty and the apprehension that people are experiencing. As I mentioned, another very important dimension of our current situation is the role that electronic communications play, social media, and so on. We now live in a different kind of information ecosystem that we might have in the past, and that is a major driver of concerns that people have and at times of more or less adaptive strategies for coping. So I'll just rehearse very quickly the evidence that we have to date, which is mostly from online surveys of a huge increase in emotional distress, that is to say anxiety, dysphoria, depression, common mental health problems around the world, really everywhere that people have looked, both in high income and low and middle income countries. And these rates vary from 20 to 40 to 60, even to 80% of the people surveyed. Of course, these are online surveys. There's no way of knowing usually how representative they are. They represent people who do have access to the internet and who are being reached in some way. So they need to be taken with a grain of salt, but they certainly give us a sense of some of the parameters. And in fact, because more people have been driven online to transact their lives there, these surveys may be a little more representative than they have been in the past. And you can see this in, there are already a couple of synthetic surveys, meta-analyses, and so on, demonstrating these high rates, and particularly high rates, as Joanne has just alluded to, among health professionals who are exposed to the immediate threat of infection, but also to the grief and pain of seeing people endure this illness and loss of life, and loved ones who are unable to be with people who are going through mortal illness in some cases. So, yeah, again, I'm not going to belabor any of this. I'll make all this available, and none of this stuff is very difficult to find. If you look at the kinds of symptoms and experiences people are having, you can see at the bottom there, the most frequent things have to do with anxiety, depression, anger, the sort of common emotions associated with distressing situations, apprehension, loss of loved ones, loss of functions, loss of social roles, and of just all the supports that we get from everyday life. So that's the kind of area that we're talking about. The same stressors exacerbate pre-existing problems. People with obsessive compulsive disorder, for example, who already had germ phobia, may have their condition aggravated by this. People with severe mental illness who have experienced the effects of the stress and confinement may have a worsening of their condition. So there are a lot of other things going on. There's a lot of new emerging data that is going to help us understand some of the dynamics of this new situation. Here's a study, I think, in Press in Canada, and these are some of the, with a sort of multivariate analysis of independent contributors to increase experience of stress and distress. And these are some of the factors that were associated in the study. They all make sense, obviously, when you look at them. And there are personality traits that play a role, but there are things that have to do with the everyday activities, time that one can spend exercising, doing artistic activities, other kinds of things that might be ordinary coping and quality of life issues for people. Here's a study that looked at some of the, actually the same study looking at the kinds of stresses that people noted that were concerning them. And again, you can see the relational sources, concern about loved ones, children, and so on, not coping well, difficulties in accessing services, and then various kinds of impacts of the shutdown. Now, this is in Canada, as I say, in a high-income country with plenty of infrastructure and a fairly coordinated public health response. So you could say this is one of the best one of the better scenarios, even though we have our own problems here in Quebec and elsewhere. You can also see from that same data set that the initial response to the sort of confinement was a higher level of distress and then gradual accommodation. So if it's a finite time period and people are hopeful about an end to it, then you see quick adaptation and resilience in most settings. The problem is when you have repeated resetting of the time frame, new challenges, new fears, new anxieties. Of course, this has been going on in parallel with other global forces, political polarization, anxieties about climate change, natural disasters, and so on. So all of those sort of add new waves to this process. And in particular, as I've already mentioned, the concern about there not being a definite end to this and to life having permanently changed in some ways is, I think, a whole other set of circumstances that we're just coming to terms with. This is a study that looked at predictors of increased risk for child abuse, what are the stressors sort of on parents and that they're finding challenging. And you can see again some of the things that people put at the top in terms of their concerns that are similar to the previous slide. So making sense of these things, I think, is important for understanding both the elicitors of emotions and the ways in which emotions can become part of cycles of exacerbation or of coping and resilience. And finally, here's some data from the US, just comparing rates of depressive symptoms among adults with a population survey data from the previous year. And again, you can see substantial increases across the board in the population. So let me just say a few words then about how to approach these things from a cultural, cross-cultural point of view, because there's a tendency to think of emotions as universal. We can use a language of fear, anger, so on, and be somewhat understood by people in very different cultural backgrounds. But in fact, there is large variation across cultures in emotions, as you may hear from Lisa Feldman-Barrett shortly. Cultural and context affect every aspect of emotion, both the biobehavioral systems through which we learn to approach the world and attach valence to events. Some events are positive and some are negative, some are draw us toward them, some are repel us, and so on. So although there are basic systems like a disgust system or a threat avoidance system and so on that you can argue are evolutionarily built in, the configurations that they take, the meanings they have, the ways that we live with them vary widely across cultures. And we need to get a handle on that if we want to devise methods of helping people to cope with these situations. This has been a problem in global mental health research because we tend to use standardized tools mostly produced in the West that don't sort of look outside the box. When you do look outside the box, you notice that there are things that are being left out. And this is a kind of a review or a commentary on a review that looked at qualitative research pointing out substantial variations in the way that something like depression is experienced. Even when you start with a sort of syndromic definition of something, of a cluster of symptoms and feelings, you find significant variation. So it's important to understand emotions in context with what we could call an ecosocial view that sees emotions not just as intrinsic processes in the person, but as interactional or transactional processes. We participate in emotions with other people. The emotions represent social scenarios that we can imagine or that we're living through. Other people are important for how those scenarios unfold, and that is part of how we regulate our emotions, not just internally through our own interpretations and responses, but equally through our interactions with other people and their responses through a process that we could call kind of thinking through other minds. And the context that we're then responding to are made up of other people, made up of social institutions, made up of domestic space, increasingly made up of a kind of virtual network that is affecting how we adapt. Oops, going wrong direction. And so finally, I'll just suggest that one way we could begin to approach the relevant emotions that are being mobilized in a situation of massive social challenge is to work with a framework, something like this one that was developed by Derek Siloff to talk about the impacts of torture and massive human rights violations, but I think it can be adapted to talking about our current situation. And partly this was devised by him to push back against the emphasis on post-traumatic stress disorder and trauma-related syndromes in contexts like torture and massive and civil strife and so on, but to insist that even in those situations, there are all these other dimensions to people's suffering and experience that need to be considered. And I think it's easy to see how each of these dimensions is affected by the current pandemic, and each has associated with it particular kinds of emotions. You can see in the fourth column here sort of the initial response that people have to problems in that area, and then the kinds of adaptive strategies that we tend to make use of to cope with these things, and then what happens when those adaptations are not adequate or sufficient to address the situation. So I think this kind of framework could be elaborated further in the context of COVID-19, the particular kinds of threats it represents, and the particular kinds of changes in the social world that come about as a result of our mitigation efforts. I'm not going to belabor the rest. I'll make this other point that those configurations vary widely, but we can understand them broadly in cultural terms as being oriented around different notions of the person. And most of our health psychology, most of our models of emotion and adaptation that come from academic psychology are heavily individualistic in their orientation. They look at inside the person and how we regulate ourselves, how we organize our behavior. But there are other frameworks that are important all over the world and for all of us, of course, but where the emphasis really varies. And the most common one perhaps is what we could call a sociocentric or collectivist or familist approach that understands emotions and experience and adaptation as being rooted in relationships between people, but we also have notions of the person that connect people to the environment very deeply. This is very important for Indigenous peoples in many places, some of the people that I work with here in Canada, and what we could call a cosmocentric view, a view that recognizes that there is an invisible world, a vertical dimension to life that speaks to larger meanings and so on, that then becomes a kind of focus in how people adapt. So in conclusion, I think we need to approach the whole issue of emotions from this more situated point of view that respects cultural difference and diversity. We have tools for this now coming from cognitive science, from what's been called 4E cognitive science, that insists that all experience, and particularly emotional experience, is embodied, it's embedded in a particular social context, it's enacted, it occurs through action, not just through reflection or representation, and it is extended, that is, it depends on other people and social institutions. This leads us toward having the conceptual tools to begin to recognize local variation and broader geographic variation. We now have this challenge in the current moment of exploring new configurations of the social world. And in particular, something that concerns all of us greatly, I think, is addressing issues of epistemic authority and epistemic justice. That is, who do we trust? What kinds of knowledge is reliable? Who has a say in what's going on? How do we negotiate conflicts in this domain? So I'll stop here. I don't know. I didn't have a clock running. I don't know how badly I've abused my time frame here, but hopefully we have some time for discussion.
Thanks very much, Lawrence. It's been really from the personal perspective and health worker perspective to the cultural and the societal context has been really helpful for moving. We don't have a lot of questions, so I didn't want to cut you off. I thought in fact, we only have one, which is really about just endorsing the importance of culture for particularly configuring and delivering messages. And that's where I think in some of the communications and response strategies, one of the mantras of the Vaccine Confidence Project is that it's not just about trust, it's about building trustworthiness. And I think you talked a lot about the relational nature of this. It's not a one-way, go out there and build trust, it's go out there and earn it. And it's very relational, and it depends on community. And I think also Joanne's presentation ended up ended with the absolute importance of community and owned experience of this. I think that was a really important point, but also the practical repercussions in both of your presentations. I mean, Joanne talked about, you know, you go home at the end of the day and it's not just about the emotions at the front line, it's your emotions and concerns about the spread, or how you might affect or infect others. And I certainly know from having worked a lot also on Ebola, that was a very tangible, and certainly in the context of COVID. My husband had very severe COVID, so I was very, you know, really locking down to not make sure I wasn't a vector. And that wasn't even as a healthcare provider, just as an exposed person. I can imagine the degree is much more a motive for someone working on the front lines. And then you were talking about all these other, the situational things, losing jobs, losing, you know, all the different practical things that have emotional repercussions. On the PTSD, the post-traumatic stress syndrome part, we're seeing that in this phenomena of long COVID, the extenuated symptoms, sometimes well past when you were actually actively sick. There are symptoms that are showing up that are starting to be identified as actually being part of a post-traumatic stress disorder, having been through an acutely stressful anxiety. Also, the whole experience of isolation during such a near-death type of experience, you know, in hospitals, and it's I can't start to imagine, and that has various things we're seeing moving forward. Um,
Let me just comment just very briefly on that. Years ago, Aria Shalev, talking about post-traumatic stress disorder, said that it's really a disorder of recovery. Because under ordinary circumstances, I mean, we're prepared to deal with trauma. It's the sort of human condition. But what helps us over that is solidarity and comfort from other people. Bessel van der Kolk said getting a hug from someone is, you know, a big part of recovery. Well, we're in an environment right now where for many people that's not possible, or that itself comes with a freight of worry and concern. So I think this is part of the dilemma, that the usual responses that would help us to move forward are being disrupted, and this is what we have to pay close attention to.
Yeah, that's an acute one. Yeah, that's very true. Joanne, do you have any comment before we, since we don't have more questions, we'll can move on to the next panel?
No, I think I'm fine. I think that Professor Kermeyer, you know, I've summarized, you know, a lot of great, you know, thing to think through, and I would just skip. But I think that for me, emotion, that would be that my only comment. Emotion has been the blind spot of authorities about how to tackle COVID-19, and I think that is so, I would say, timely to have this webinar right now, and we absolutely need to make it part of, I would say, the core issue or theme to address at the outset of an epidemic.
Yeah, that's an important and perfect note to end on, that will be shedding light on the blind spot, I hope, and this is the beginning, and just thank you so much. That was a perfect way to really get us thinking and move into a different kind of session, but very related. Clarissa, I'll turn over to you to introduce the next session, and thank you both again. I hope you can stay as much as you can for the next session.
Thank you, Heidi. Hello, everyone. My name is Clarissa Simas. I'm a psychologist and a research fellow at the Vaccine Confidence Project. And together with Professor Larson, I'm contributing to the Atlanta Commission of Emotional Determinants of Health. So today I'll be chairing our second session of this webinar, our second panel, which is about how emotions can affect health outcomes. We're going to start with Professor Lisa Feldman-Barrett. Due to time zone differences and conflicts in the agenda, she couldn't be present with us now, but she was kind and recorded her presentation before, and I'll play this to you now.
Hi, everybody. Greetings to you, wherever you are in the world watching this. I am coming to you from Boston, Massachusetts. I'm very, very grateful for the opportunity to talk to you today. I particularly want to thank Dr. Heidi Larson and Clarissa Simas and everyone at the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. And I'm very, very honored to be speaking to this group of scientists and scholars and responders and caregivers today. And I'm really happy to be speaking with a bunch of fellow Canadians. It's been a really good week for vaccines in relation to COVID-19. We saw that Pfizer released news that their vaccine is over 90% effective in the latest trials. And so today, what I want to do is talk to you a little bit about the role of emotions, both actually in terms of who is likely to get infected upon exposure to a virus, and also potentially who is most likely to benefit from the vaccines when they are available. I only have, 10 minutes, so I'm going to really take this at a pretty quick clip, and I'm going to just try to hit some high notes and then give you some resources that you can follow up on if you're interested at the end of the talk. So the first question really that I want to address, and maybe the question for the entire talk, is who develops respiratory illness upon exposure to a virus? Everybody? Most people? Only some people? Well, it turns out we know something about this a bit, because there was a set of studies performed between 1986 and 2011 led by the psychologist Sheldon Cohen. This was called the Common Cold Project, and it was a series of prospective viral challenge studies that were conducted out in the world. Dr. Cohen and his colleagues placed viruses into the noses of healthy people, including a coronavirus that is linked to the common cold. And he and his colleagues observed who developed respiratory infections upon exposure. In 5 studies, between 20 and 40% of the people who were exposed developed illness. That means at least 60% of people who were exposed to the virus did not develop respiratory symptoms. And this indicates that a virus is not a sufficient cause of illness. Chronic stress, emotion, social isolation, social and economic disadvantage, childhood adversity, and other psychosocial factors seemed to confer risk, social integration, social support, positive emotions, and high-quality relationships with parents in childhood seemed to confer resilience. It's tempting to assume that a virus is the major cause of respiratory illness, that a virus works kind of like a mechanistic system infecting the body in this very, very mechanistic way, and that any psychosocial factors are subsidiary and merely moderate the virus's impact. After all, you can't develop respiratory illness without a virus. But a virus is not the cause, because, as we saw, only between 20 and 40% of people across these studies developed respiratory illness, respiratory infection upon exposure. So respiratory infections, like most biological phenomena, most likely emerge from a complex web of weak interdependent causal factors. That is, it's a complex system, that the virus and the body and the brain are a complex system. A virus doesn't merely replicate itself from its genes in a passive human body. It has the capacity to cause infection only when the body's cells and immune system and brain are in certain conditions. So basically, the biological state of the host is also a necessary condition for illness. The ensemble of brain plus body provides a necessary environment for a virus to develop and cause an infection. The human brain plus the state of the human body contributes basically to the likelihood of its own infection, in part by the mental phenomena that it creates, which in turn are linked to immune and metabolic function. So in a very real way, the probability and severity of infection at any given moment, as well as the resilience, that is exposure to a virus but with no symptoms, is actually a unique confluence of a virus in a body with a thinking, feeling, and perceiving brain. So both the virus and the brain plus body work together in a sense as a complex system. Neither one is a sufficient cause. Neither one should be ignored in science or in practice. And so in this view, psychological factors, including emotions, may be actually thought of as necessary causes of respiratory illness. They're not sufficient to develop respiratory illness, but then neither is a virus. To understand a little bit about how this works, we have to take your brain's perspective. So for your whole life, your brain is entombed in a dark, silent box called your skull. It learns what is going on around in the world only indirectly via scraps of information from the sensory channels of your body, like sights and sounds and smells and so on. These sensory changes are the outcomes of things that are happening in the world. They are the effects of things happening in the world. Your brain has to figure out what caused these sensory inputs so that it knows how to act to keep you alive and well. But there's a tricky bit. The sensory information can be noisy, ambiguous, and incomplete. And any given sensory input, like say a flash of light or a very loud bang, can have many different causes. So consider a loud bang. That could be someone dropping something on the floor. It could be someone slamming a door. It could be one car hitting another car in front of your house. It could even be a gunshot if you live in the United States. And in much in the same way, your brain also has to make sense of sensory changes that are coming from your body. So for example, an ache in your gut could be hunger. It could be anxiety. It could be a gut feeling that a defendant can't be trusted if you happen to be in a courtroom. Similarly, an ache in your chest, a pull and tightening in your chest could be anxiety. It could be having difficulty breathing because of running up the stairs or having exercised or in coming close to your ventilatory load, or because you're starting to develop respiratory symptoms or even the beginnings of a heart attack. So your brain has to determine the causes of sensations when all it has access to are the outcomes or the effects. This is what scientists and philosophers call a reverse inference problem. How does your brain solve this reverse inference problem? Well, it has one more source of information: your past experiences. Your brain is basically constantly remembering past experiences that are similar in some way to the present, to what is going on around you right now and in your body. So what is similar to the present conditions. So your brain, figuratively speaking, is not asking, what are these sensations? It's asking, what are these similar to? Now, in psychology, a group of things which are similar are called a category. So in a sense, what your brain is doing is it's using past experiences to dynamically create categories on the fly. It's bringing past experience to bear as knowledge to reinstate patterns that are similar to the present. So the brain is remembering. So it's not a conscious experience of remembering. Basically, your brain is reinstating these patterns from your past, often in novel ways, which we call generativity, to create representations that are similar to the present conditions as a way of guessing at the causes of sensations in order to make a plan to do something about them. So what you would do when you have an ache in your gut, whether you would eat, whether you would ask for help, whether you would find somebody guilty, all depend on how your brain makes sense of those sensations. Similarly, what you do when you have an ache in your chest depends on how your brain is making sense of your sensations. So you could say that each category that your brain makes in each moment is actually a population of possibilities, a population of opportunities, a population of guesses about what to do next based on the current situation. In this way, emotions are made, they're not, emotions are built as you need them. They're not built into your brains. They're not reactions to the world. They're your brain's constructions of the world, or rather, a better way to say it is they're your brain's understanding of what is going on inside your own body in relation to what is happening in the world. Categorizing, creating categories to make sense of what is going on inside your own body, like an ache, in relation to what is happening in the world, so your brain can figure out what to do next to keep you alive and well. And in a very real way, variation is the norm, because every time your brain is making a category as a way of explaining sense data in order to act on it, your brain is creating a whole set of opportunities or possibilities or possible futures. And each time your brain creates a category, it may not look like any other time. So when your brain makes a category for anger in one situation, that may look very different than the category that it makes for anger in another situation, or for fear or any other emotion category that your brain is capable of making. So emotion categories, just like people who are developing respiratory illnesses or not, are populations of variable instances. And in fact, this was a concept that Darwin introduced in On the Origin of Species, and that the biologist Ernst Mayr calls population thinking. So the big takeaways here are, first, that when it comes to brains and bodies, whether we're talking about emotion or we're talking about who gets sick by exposure to a virus, variation is the norm. The common cold studies show really clearly that the mind and the body are linked, not in some vague metaphorical way, but in a real probabilistic biological way. What we think, what we feel, how we experience the world, and who we experience it with translates into vulnerabilities or resilience to illness. We don't really know how mental events like the experience of fear or anger or awe or gratitude are transformed into physical conditions like immune function. But this is something that scientists are working on, and maybe even some of you are working on. And I guess the thought that I would leave you with is an absence of knowing everything is not the same as knowing nothing. The Common Cold Project clearly suggests that at least for cold viruses, one of which was a coronavirus, and so this may generalize to other viruses too, like COVID-19, that psychosocial factors leave a brain more or less able to regulate the pro-inflammatory cytokine response upon exposure to a virus. Other research has established a relationship between other biological conditions and stress and emotion that are really important. So for example, people who are chronically stressed have shorter telomere lengths, and this increases pro-inflammatory, chronic stress increases pro-inflammatory cytokines and also encourages a poorer antibody response to vaccines. And people with shorter telomeres, particularly in white blood cells that help mount an immune response to pathogens, have an increased risk in respiratory illness. Now, if you want to find out more about these ideas, some of which I know sound pretty outrageous to you, but I can tell you that they're based on the best available science that certainly that I know about. You can look at my book, How Emotions Are Made, The Secret Life of the Brain, and as well, for a fuller discussion of these ideas and the science behind them, you can look at my new book, which comes out next week, November 17th, called 7.5 Lessons About the Brain. I'm really sorry that I couldn't be with you in person, well, virtually in person today. But if anyone would like to reach out to me, please email me at l.barrett@northeastern.edu. If you Google my name, you can find the email address easily. Thank you again for listening to my talk, and I hope the rest of this conference is informative and useful to you.
So that was Dr. Barrett's fascinating talk. And now I'm gonna pass the floor to Dr. Madhava Balakrishnan, who's gonna talk to us about immunization stress-related reactions in the time of COVID-19.
I think I'm muted. Yeah. Hello. Thanks, Clarissa. Thanks a lot. And thank you very much. First of all, I want to thank the Vaccine Confidence Project, particularly Heidi Larson and team for giving me an opportunity to share with you some of the information which is very pragmatic and also what would be probably helpful in the middle of this COVID crisis. And particularly, we know that vaccines are coming up very, very quickly. And where should we kind of focus on, and what are the things which are totally related to something like a new topic, which is actually this immunization stress-related responses. So, so I'm actually going to just share my screen and 1 minute, just a minute. I'm just having some difficulty. Yes. Okay. Let me share my screen. Is it visible?
Not yet.
I'm having some problems with this.
I can, let me see if
Just
I can.
a minute. No. I think I've got it.
Okay, perfect.
Minute. Yes. So let me display the screen. Is it visible now?
Yeah, now I can see it, yes.
Okay, excellent. So this is, as I was just mentioning right now, this immunization stress-related responses is actually a little bit of a new topic because basically it is any factor or effect which occurs after immunization, which is not related to vaccine product, a quality defect, or which is actually not related to a coincidental event. Now, the thing is, we will be just going through a very, since I just have only 10 minutes, I'll be just sticking on to the very practical aspects of this. So when you just look at this, and I wanted to be focusing on what is it related to, particularly in the COVID context, in the COVID vaccination context, how is it relevant? So when you just look at what is happening to immunization sessions right now, if you see the context in which immunization sessions are occurring right now, it is occurring in certain very, very closed situations, like, for instance, where children are vaccinated in schools. It could be happening in immunization sessions which are happening in particular clinics, and also which would be happening sometimes, if you just look at it, there will be certain centers where vaccinations are being conducted. Now, again, if you just see what is going to be happening from the COVID perspective is going to be quite different. When you look at what is, now we have one vaccine which Pfizer says that it is ready. We are also having other companies, which are just coming forward saying that vaccines are ready. But when they are actually going to get operationalized, we are anticipating a lot of issues, particularly when you look at it in terms of rolling out those campaigns, and also from the safety perspective. There is a lot of challenges which we are anticipating, and anticipating this from WHO, we have actually developed certain, we have developed the guidance documents for this, as well as we are also developing certain specific training modules, etc. for this. So when you look at it, what exactly is going to be happening is we are going to be completely, the way in which vaccinations are going to take place for COVID is we'll be having a completely different approach. And how is this going to be different? What is going to be happening is there are three differences which we can anticipate. One is related to the vaccine itself, then it is related to the vaccinee, and the third one is also related to the vaccination. Now, when you look at it in terms of the vaccine itself, as I just said, now we are getting the vaccines which are coming up. Even if you just look at the Pfizer vaccine, for instance, these are new types of vaccines in a particular platform which has never been used before. And it is being used for immunizations for the first time. And also when it is being used, we also normally what happens is when you look at the life of a vaccine for it to be developed, it is usually something like about it takes us about 8 years minimum to have a fairly good vaccine, which is well tested and the safety profile is kind of well developed. But what is going to be happening now is we have got accelerated clinical trials with less than a year, and then we are kind of trying to extrapolate that, particularly the safety and the efficacy components onto the field. The other thing is when you look at countries like, for instance, big countries like in India, for instance, or big countries with huge populations like Indonesia or China, multiple vaccine brands would be used in the same country at the same time. And sometimes, you're going to get a lot of problems related to this. The other issue is already we heard that, the vaccine which Pfizer is coming up needs special storage techniques like, minus 70 degrees and things like that. And at present, our systems are not tuned to it. And on top of it, the technique of administration, even things like, mixing the vaccine, the vial with the diluent with the vaccine, it becomes very, very, it's sometimes very difficult and complicated. Now, so with regard to the vaccine, this is what we see. With regard to the vaccinee, what is happening? Now, when you look at it, normally when you look at vaccines which are being given, most of the vaccines are being given for children under 1 year of age, or mostly under 5, we can say. But right now, with COVID, we are going to be having vaccines which are being given for all age groups, including senior citizens. So just imagine, you're going to be finding situations where people in wheelchairs are going to get vaccinated. And so it's going to be having a completely different, vaccinee, the target population. Again, if you just look at the profile of the vaccinee, it's very heterogeneous in the sense people can belong to different races. They can be belonging, for instance, people can be well-nourished, malnourished. You can have Caucasians, people from Africa. So all those heterogeneous profiles will be there. Then there can be comorbidities. This is another thing which we are very much worried about. People can be HIV positive. They can be having hypertension, diabetes, so many other things which we are not normally seeing with many of our target vaccinees. Now, when you look at the other things, many of them could also have occult diseases which have not manifested, but which would manifest when vaccines are administered. And also some of the vaccinees would be in long-term medications. And the last point, I think I should have probably put it up in the first, that is most of those vaccinees for COVID are actually going to be influenced by social and other media. And that plays so much on their emotional, and as well as they already come with preconceived ideas on how the vaccine is going to be and how they are going to react to it. So when you look at the vaccination process itself, the issue is, again, we are going to be facing a lot of challenges because there's going to be non-traditional vaccination locations. When you look at the way in which traditionally, as I just showed you some of those pictures in the beginning, you will see that those are very clear-cut, usually in the way in which vaccinations are being conducted, including mass immunization campaigns in many parts of the world. It is done like a very military operation, It's done very clearly. People know exactly what number of people to be vaccinated, who will do it, how will it be done, what will be the impact, etc. They know. But now, with this entire changed scenario, we are going to be having a lot of non-traditional vaccination locations. And the other thing is, the vaccinators themselves are actually going to be of a completely different profile. So the kind of training which we need to be doing for these new vaccinators are also completely different. So we are from WHO and from partners, we have been UNICEF and other Gavi and all other partners, we have kind of planning and preparing for all these kind of things. The other thing which also comes up is also vaccinating in the context of giving social distancing. It's a completely new concept for many of our vaccinators. So these things need to be really thought of. New procedures and technique which are not conventional. And also the other thing which when you look at it in terms of duration of follow-up, for instance, we know that certain vaccines after vaccination will have to be followed up for a particular period of time. But with COVID, we have this the fear of this enhanced disease which can occur. We really don't know whether we have to follow them up for 1 year, 2 years, or even beyond. So there are a lot of unanswered questions also, like right now what we are worried about. And only one of those unanswered questions is this immunization stress-related responses. Now, originally, this is how the WHO classifies adverse events following immunization. So there are 5 classes of AEFIs. So if you just look at the first class of AEFIs, it is actually a vaccine product related reaction, which means the vaccine itself or the substance or the medicine of the vaccine causes the adverse event. The second one is a vaccine quality defect related reaction, which is actually where there is a problem at the time of manufacturing, and as a result, the adverse event can occur. The third one is an immunization error related adverse event. And this is when there is a problem in terms of administration, like there is a mistake which is made during administration which caused the event. The fourth one is an immunization anxiety related reaction. The terminology has been changed from immunization anxiety related reaction, which was originally designed. In fact, this was designed in 2012. So last year we had WHO changed this terminology into an immunization stress related responses. The reason why we changed the terminology from anxiety to stress-related responses was that it was realized that anxiety is not the only adverse event which can occur. On the other hand, there is an entire spectrum of diseases, of manifestations, of psychological manifestations which can occur after vaccination. And that is why the terminology itself has changed into an immunization stress-related responses. A coincidental event is the last one, what you see there on the screen right now. And what it means is it is an event which is an adverse event which is caused by something other than the vaccine product or an immunization error, etc. Normally, what we do is we can just divide it into 2 things, like something from outside coming into the body. Like for instance, you vaccinate and then you get meningitis. Later, you find that it is because of Japanese encephalitis or something like that. That is a coincidental event. So these are the kind of adverse events which is usually seen with regard to after vaccinations. Now since this topic is on COVID vaccinations and immunization stress-related responses, I just want to place certain things on the table. Now, as I said, one of the interesting things about this immunization stress-related responses is, technically speaking, it is not an adverse event following immunization. Because, for your information, this is among the list which I just showed you earlier, among the 5 conditions which I showed you earlier, this is the only condition which can occur even before vaccination or during vaccination or after immunization. Because most of the others occur during or after immunization. That is something we have to keep in mind. Now, when we try to explain this, there is a biopsychosocial framework which was kind of explained, which we have to understand. So when you look at it, I'm going to just go into the certain things. That is just going to explain certain things right now here. That is, there are certain biological factors which when there is an interplay with the psychological effects and social effects together, contribute to the occurrence of the immunization stress related responses. This is characterized by 3 things. One is there could be certain events which are predisposing, that is before the vaccination itself. So people, like right now, if you see, based on what people are seeing in the media, all the news they are getting, what is there in the social media, there is previously itself, based on this, people themselves are becoming tuned to having a particular approach for COVID vaccinations. You would always be seeing that there is a group which is already saying we don't want to vaccinate, and we are saying that we want to vaccinate. So these are the historical contexts or the predisposing factors which are involved in the vaccination. The precipitating factors are the factors which take place around the time of immunization. So at the time when the injection is being given, so that is the precipitating factors which really take place at the time of vaccination. And perpetuating factors are factors which occur after vaccination, where when you follow up the person for a period of time, that is when you start having certain manifestations. So we are going to be dividing the next part of my talk. I'm just going to be focusing quickly on the 3 points here. So let us look at the predisposing factors. So if you just look at the predisposing factors, as I said, there could be biological factors like, age group. So if you just look at it, for instance, young babies, they don't really have anything to think about. Like when you look at it, infants under 1 year, they're not worried. But when you're looking at it from the COVID context, people, as I said, as they are older age groups, there is already a vulnerability. It's a different kind of an approach which you're going to be having. There is a psychological makeup there, based on previous negative experiences, particularly with injections. And sometimes these kind of historically, you find certain parents in particularly developing countries, they threaten children, like, they tell children, if you don't behave, I'm going to take you to the doctor or the nurse for an injection. Those kind of things can actually have huge amount of impact during vaccination. And also certain, the history of acute stress responses. But I think of the lot, the biggest worry we are facing is actually with the social media, because right now you see how strong it is, to receive negative or positive information from family, friends, and mostly the negative ones are what people retain. And also the other thing which also happens is, actually historically what we see is, from the WHO's experience, we find that people take videos and these videos get circulated all over the place. And that is probably one of the important reasons why we are going to be getting the immunization stress-related responses. So coming to the next one, when you look at the peri-immunization context, the precipitate, this is what is happening at the time of vaccination. So again, at the time of vaccination, you can look at it, you can divide it into 2 categories, where it is done in let us say in a private clinic on a one-to-one basis at an individual level, or it is done in the form of a mass campaign. Like, you find that people are coming in groups for getting themselves vaccinated. Now, when you look at it from the individual level, again, the same, you have the biological factors, psychological factors, and social factors, which have an impact. But again, one interesting thing here is, certain things like biological factors, like, prolonged standing and the individual's experience to pain, because each person reacts to pain differently. Some people have
so sorry to interrupt. If we could just wrap over in the next minutes, because
10 minutes, no problem. I've kind of quickly finished. I'm just finished.
Thank you.
Okay, thanks a lot. Okay, so this is the post-immunization factors which we were just talking about. And then what we are worried about is actually the ISRR clusters. You have multiple adverse events which are occurring as a group in the form of a cluster. And this is one more thing which we are actually worried about. If you can just click on this link, it will give you more amount of information. Now, I'll just talk, I've got only 2 more slides, and with that, I'll be completely stopping. Now, with regard to this, what is our biggest challenge right now? The first one is whether we want to worry about is to differentiate ISRR from serious conditions like anaphylaxis, for instance, which are, when you look at conditions like anaphylaxis, they are very rare, they are life-threatening, and they need special medication, and also epileptic seizures, for instance. And wrongly diagnosing and treating ISRR, immunization stress-related responses, as anaphylaxis or conditions like epilepsy can have serious implications. The other challenge which we are actually facing, it's a little bit of a busy slide, but I'll just quickly explain. The thing is, when you look at the differential diagnosis, there are so many things which it can simulate that it is very difficult for us to understand whether it is a true immunization stress-related response or whether it is a coincidental event. So this is also one more big problem which we are facing. So this is my last slide. And what is WHO doing with regard to ISRR in the COVID context? What we are doing is, right now we are actually conducting specific training for healthcare workers to preempt, identify, and respond to immunization stress-related responses. Specific guidances are being provided to program managers. And also what we are doing is we are working at the country level, right at the grassroots level, to develop micro plans where we can actually take into account immunization stress-related responses. And also we are having a specific communications approach when the communication plans are also being made, and also to consider vaccine safety crisis in the form of immunization stress-related responses as clusters right at the highest level so that can be preempted. So I'll stop here. Thank you very much.
Great, thank you so much for the presentation. Our next speaker is going to be Professor Robert Horn from UCL. Professor Horn, without further ado, I'm going to pass the floor to you. Thank you.
Hi, thanks. I don't know if you can hear me. Can you hear me?
Yes, we can hear you fine, yes.
Clarissa, I'm really sorry. I've had difficulties on the technical side with joining, and I haven't been able to hear until now anything that's said, so please forgive me if my comments are a little out of tune with everybody else, but I think you wanted me to speak for a couple of minutes, 10 minutes, on the role of sort of cognition and emotion in how we make decisions about healthcare. So I thought it might be helpful if I can, is it possible to share my screen?
Yes, sure. Yes, please go ahead.
That's great. Okay, so I just want to show a couple of slides. Okay. So I'm not showing the, whoops. Okay. Okay, so I think the way to understand this is, you know, it's often, we often separate sort of rational thinking, if you like, from emotion. And we know that emotion is incredibly important. How we feel about something is very important in determining what we do and how we might respond to health advice. And I think in a way, the separation between cognition and rational thinking and emotion is kind of not that helpful in some senses, because the two are so intimately linked. So what I wanted to share was an idea that comes from Jonathan Haidt, the sort of psychologist and ethicist, as a good model for understanding kind of how we work as humans, and also how we might understand this interaction between our cognitions or rational decision making and our emotions. And he uses the analogy of the rider and elephant. So, you know, how we kind of work is that we have a rider, or our rational brain, which is our conscious processing, which deals with planning and problem solving. And here we make decisions that, you know, we think are influenced by evidence. So for example, if we're trying to decide which is the best laptop to buy, we'll look at different laptops and their various properties and try and compare that against what we think we want from the laptop. And we sort of see that as an entirely rational decision. But the first thing we need to recognize is, even at that level, those decisions are strongly influenced by the beliefs that we bring to the decision. So for example, we might have pre-existing ideas about Mac versus PC, etc., and ideas about style and the look of the laptop. So even at the rational level, our beliefs are important. But also the other side of our decision making, and indeed our thought processes, is, if you like, the elephant. And this is what's often called our emotional brain. These are sort of our instinctive, unconscious processes, but they're not just really emotion. Emotion is kind of, in some ways, a physiological response to a cognition. So things like fear or excitement are physiological responses. Often when we talk about emotion, what we mean is this unconscious brain. Other people have called it the lizard brain, you know, our sort of processing, which we're not often aware of, because it happens very quickly. And the best way to think about this is unconscious instinctual processes, what Daniel Kahneman calls thinking fast and thinking slow. So our thinking slow is the rational brain. What's the best laptop? You know, should I take a vaccine for COVID? And those are sort of things that we might debate and think about. But actually, also we need to recognize that many of our decisions are influenced by this unconscious, instinctive, fast processing. The point we need to understand here is that both need to work in partnership in order to move forward. So, but we ignore the strength of the elephant, the emotional brain, at our peril. You know, imagine if the rider and the elephant disagreed about the direction of travel, which one do you think would win? So when we're thinking about people's behavior, if we want to influence it, we really need to align both the rider and the elephant, but also make the path ahead as sort of straight as possible. And what we mean by that is if we can make the behavior as easy to do and convenient as possible, that's also a good thing. So let's think about this in a little bit more detail in terms of how people think about illnesses. What we do know is that we have an information action gap. So recommending on the basis of evidence that someone does something like receive a vaccine or take a prescribed treatment, we know is fraught with difficulties. For example, WHO estimates that about half of prescribed medicines for long-term conditions are not taken as advised. And we know from Heidi Larsson's work and others, the difficulties of vaccine hesitancy and trying to encourage people to engage with vaccination. And you know, this is really the information, or you might label it as evidence action gap. And in order for evidence to make us do something, it needs to either agree or change our beliefs about that particular behavior. And that's where we often encounter problems. And I think this simple framework can help us to understand why people's beliefs often don't align with the evidence. And it's the necessity concerns framework. And it's really like we need to understand two types of beliefs that the person might have about the action. A necessity belief is not the same as believing that it will be beneficial or effective to follow the advice, but rather is the answer to two questions that we ask ourselves. Firstly, how do I need to do this to achieve something that is important to me? And can I get away without doing it? And we ask the second question because we often have concerns about the downside of engaging with a treatment or following health advice or vaccination. And so in order to help people to make an informed choice, we need to consider how we present the information. So have we made a case which makes common sense to them to answer those two necessity questions? Why do I need to do this to achieve a goal that's important to me? If we look at the example of vaccination, that may be understanding the benefits to the individual or communicating them in a way that means something to them. Or it might be about bringing in some evidence of vaccination helping others that's relevant to the person. Also, we need to understand the legitimate concerns that people have and address them. And then coming back to my previous slide, we also need to recognize that this isn't entirely based on rational processes and evidence. So some people's concerns may be based on more background social representations of pharmaceuticals bad, not trusting the government, and the vaccination is an agent of the government, etc. So we really need to understand both the rational decision making, but also how the personal evaluation of necessity and concerns may be influenced by unconscious processing and sort of, if you like, background social representations that we may not be aware of, but will influence our decision nonetheless. So I'm conscious you wanted me just to give a brief overview for 10 minutes, so I'll stop there and ask if there are any comments or questions.
Thank you, Robert. That was a fascinating presentation. I'm going to pass it to Heidi now because I believe she had a few comments to make, a few closing remarks to make at the end. Thank you.
Thanks so much, Rob. We've kind of, we're running out of time here, but, and the questions we have, actually, there's one I'll throw out to you. Most of we just have a few, and a couple of them are more comments, but here's one just to a note to end on. My hobby's dancing, and it feels like it gives me good strength. But I have a concern. If somebody falls ill, that person could feel guilty or blamed for not being mentally strong enough, leading them to a downward spiral of emotions and resilience. On the other hand, a person trusting their own mental strength could become careless in protecting himself. So just someone asking for reflections on that.
That's a very thank you, Heidi, and thank the questioner for that really interesting reflection. And I think that illustrates entirely the point I was trying to make about how the necessity and concerns evaluation are really influenced by personal processes that go beyond the evidence. And so the importance of this in terms of how we try to communicate with people in a way which resonates and can help them change their behavior is that one size doesn't fit all. And we really need to tailor to individuals and how they are thinking about and processing that advice. So, you know, in both those cases, you have the same scenario, but two individuals who process the same information in very different ways. They both make absolute sense to them, and they are both entirely logical. But we need to understand how that goes forward in order to persuade that person.
I think that I think it's a good answer and a thoughtful note to end us on. It's been quite a journey, this webinar. I really appreciate it. We have recorded it so people who came into different points can see the trajectory from the beginning with Joanne's talking about the personal experiences and reflections from healthcare professionals and frontline workers to we heard Professor Kiermaier talk about some of the social and cultural issues, the situational issues that affect, and then between Dr. Barrett and Rob Horn, we're hearing more about the mind body and the different aspects from a more brain body, brain experience, brain emotion, and I like the necessity concerns. That one had not come up so explicitly. And then Madhava talking about the actual we talk a lot about, especially these days, in anticipating the COVID vaccine, issues around safety concerns and people's anxieties and emotions around getting a new vaccine, which brings us back to our current, or takes these bigger issues and hones it down into, okay, how do emotions affect my willingness to take a vaccine? And once I take it, the anxieties and emotions. And he points out, and there's even guidance now, thanks to some of his leadership, and even just this past year, the guidance for healthcare professionals was published on how do you help manage what is actually emotional anxiety, stress-related reactions to vaccination that's not caused by the product per se, but the experience of vaccination. And I think that has been a huge leap. It's something I've been trying to encourage a broader interpretation of what adverse events are and how they're caused. And I think even acknowledging the experience, people's experience following immunization. And I think it's particularly now in the time of COVID, where anxieties are high, emotions are vulnerable, that when we do finally get COVID vaccine, we need to be very sensitive and keep the empathy in the experience and to really try to start to build confidence around this new landscape of vaccines. Thanks so much to everybody. It's been really quite a very provocative and thinking webinar, and look forward to staying in touch. And please, for those who didn't get weren't able to be around for the whole webinar, it will be available in a link. Thank you.
Thanks, Heidi. Bye-bye.